Welcome, everybody. Thank you so much for joining us this afternoon for some of us, evening for others. I don't know if it's morning. Maybe somebody in California might still be morning. So thanks so much for joining us. A lot of you guys already know our organization, One Day Sooner. For those of you who don't, we advocate for human challenge trial volunteers and for those who want to participate in high impact research more broadly. And so we're willing to volunteer to participate in these kinds of trials to benefit, to speed development of a vaccine or to otherwise generate knowledge about coronavirus. But we're sort of only willing to do so if that's really going to benefit humanity. So benefiting, people all around the world is really key to the sacrifices that we're willing to make and sort of the root of our altruism. And so we host these equity panels trying to both inform our own advocacy and inform our own efforts, and also to sort of amplify some of these conversations. One of the things, these conversations about equity and global equity are certainly are becoming more and more prominent, I think, in public conversations, at least in the United States, and undoubtedly around the world, as vaccines are being rolled out and are being rolled out unevenly. Of course, one reason this has been so visible is not only just the vaccines, but the change in administration in the United States. The Biden administration is certainly a departure from Donald Trump, whose focus was exclusively and explicitly vaccine nationalism, America first, full stop, end of sentence. And there's a lot more to say, I think, about vaccine nationalism in the United States. But we're sort of expanding that conversation to explore what else is on the table. So you'll hear our panelists talk about Covax, about suspension of intellectual property, about some issues around the role that the WHO should play, as well as I'm sure other things that I'm forgetting. But we'll be talking about what else is happening, what else could happen in order to assure equity and assure a global and equitable distribution of vaccines, of COVID-19 vaccines. So I think one of the common threads that I see across all of these panelists is they're all thinking about what will realistically come next, and hopefully that's changed again with the new administration, but also sort of what should come next, what would really create a more equitable global health landscape. And I think they're all thinking about this simultaneously on local, regional, and international levels, which I think is one of the exciting things about this panel, as opposed to ones we've done in the past, is bringing these scholars together from all around the world. And I know that they'll share some issues that they're thinking about, and I'm sure there'll be ones that are unique as well. So the way this will all work, each panelist will have about 10 minutes to share their thoughts, their research, their perspectives, what's going on in their part of the world and throughout the world. And then my colleague Zachariah, who is the manager of the Africa chapter at One Day Sooner, will be handling the Q&A. So if you have questions, as Danny said, you can raise your hand. You can also shoot them into the chat to everyone, or to either Danny or Zachariah. They'll make sure to address those. And so then we'll have Q&A. We'll have some time for Q&A among the panelists, and then we'll open it up to everyone. So just to introduce the panelists briefly, Nelson Evaborhene is an Africa Leadership and Vaccinology Expertise Scholar at the University of Witwatersrand, South Africa. So he's joining us from Nigeria today. He's a global health-oriented physician committed to increasing access to health information and services to indigent and marginalized communities in resource-low settings. And he completed an MSc in Global Health and Development at University College London. Dr. Irene Torres is research director at Fundación Octaedro, an Ecuadorian NGO, and she is a board member of the Ecuadorian Society of Public Health as well. She's conducted studies on health education, health promotion, and community participation in context of COVID-19 as well. And Dr. Nicole Hassoun is a professor in philosophy at Binghamton University. She's also a visiting scholar at Cornell. She's the author of Globalization and Global Justice, Shrinking Distance, Expanding Obligations, and the Global Health Impact, Extending Access on Essential Medicines for the Poor. She also leads the Global Health Impact Project, intended to extend access to medicines to the global poor. So we'll go ahead and take it in that order. So Nelson Evaborhene will be starting us off.
Thank you very much. Maybe I'm just going to share my screen. I'm not sure if you could see my screen right now. Yeah. Can you see my screen?
Yes,
we can see it.
Okay, yeah, lovely. Thank you very much again for the introduction. And my name is Nelson Evaborhene. Like Mabel said, I'm a physician and I hold a postgraduate MSc Global Health and Development in the University of London. Currently, I'm in Nigeria. So I'm just going to talk about some of my works that I've done related to COVID-19 pandemic. Before I delve into the topic of today. So at the onset of the pandemic last year, I was in London. Yeah, I watched the news and I saw protests in Nigeria following lockdown in northern Nigeria, which is predominantly Muslim. And in the south, the Christian leader were demanding for the lifting of the lockdown. And being in London, I felt that in sub-Saharan Africa, most of the conditions they are different. So we have our own peculiar challenges. And so I wrote a case for community engagement on how Nigeria can use shared ideology or national symbol to engage communities. Just like in the UK, they talked about protect the NHS, save lives. So I suggested in this article how we could use like national heroes who brings who remind us of unity. So at the community level, I talked about that. We could leverage community healthcare workers. So when I talk about shifting front lines in West Africa, I was trying to compare how Nigeria could use the community healthcare worker program, which was launched in 2018 by the president. Community healthcare workers, apart from being members of the community, they could help bridge the gap and bring some trust and help to increase primary health care services during the lockdown and after the lockdown, and also for surveillance activities. But the bigger challenge arises as the pandemic unfolds, when we saw the United States acquire almost all doses, 3 months supply for remdesivir, an antiviral drug originally developed for Ebola. And so that prompted me to write on vaccine nationalism in Africa, how these dynamics are going to affect African countries, especially as several clinical trials were ongoing then. And the last one, I talked about the broader investment in public health in Africa, especially as trade integration kicked in as of January 1st, 2021. So just an overview of COVID-19 in Africa. Following the declaration as a pandemic on the 30th of January, the first case was recorded in Egypt on the 14th of February 2020. And given the fragility of health system in many countries in Africa, coupled with endemic burden of diseases, HIV, TB, malaria, the prediction initially were dire, and complicating these disruption to global supply chain during the lockdown. However, despite these challenges, as of 8th of March, I think Africa has recorded far fewer cases compared to other regions. And most of the deaths have been in South Africa, tragically. So effort in Africa has largely been collaborative through the African Joint Continental Strategies led by the African Union, African CDC response to prevent deaths, limits, prevent community transmission, and minimize socio-economic disruption. But thankfully, as the pandemic unfolds, we begin to see several safe and effective vaccines, which are additional tools for government to protect our population. However, just as we saw at the beginning of the pandemic, in the race to access PPE and other essentials, we saw the rise of protectionism, hoarding, and nationalism, especially in Western countries. Importantly, a key to achieving the goals of the African Joint Continental Strategy is access to vaccines. Like this picture shows that Canada has secured doses 5 times that is, while the UK almost 4 times. So with limited manufacturing capacity in Africa, many countries are vulnerable to these dynamics. So that brings us to what we're going to discuss today. Like, so how do we achieve global equity? How do African countries get access to vaccine amid limited supply of amid limited manufacturing capacity? So one of the ways is the Covax facility, which made a mention earlier. So I think the Covax is a very great and fantastic idea. It was launched in April to provide vaccines to countries irrespective of income, irrespective of your income level. As of today, we've seen countries in Africa receive the first dose. Like in my community where I am, where I'm currently staying right now in Nigeria, I think vaccination is expected to begin tomorrow. And in places like Ghana, we've seen over 400 doses of vaccine administered during the last 2 weeks. However, with Covax, despite being a very brilliant idea to ensure equity, there are still challenges, apart from the delays. Like I think in London, I was in London in December and vaccination began then. I think it took about 2 months later before most countries in Africa, started the vaccine. So apart from that, I think there are challenges in funding and as well as supply. So for Covax right now, I think the impact from the disease is still early to predict. However, most countries that have received the doses have begun vaccinating the vulnerable group, just in Nigeria, like where I was working before I went to studies in hospital. They've received their own dose of vaccine. But the question lies right now, is Covax enough to achieve herd immunity to suppress community transmission? According to the director of the African CDC, John Nicole Hassoun, this will not get the pandemic out of the continent. So achieving herd immunity in Africa requires 60% coverage of about 1.2 billion people. So in order to complement this effort, the African Vaccine Acquisition Task Team has secured additional doses of 670. But the question here, when are these vaccines going to be available? We're still unsure. So right now, what we are seeing in Africa right now, it's a lot of countries and the African Union, they are looking towards China and places like Russia. And we've seen China donate vaccines to UN troops and to Zimbabwe, which have received their second dose. So the question, is this a global public good or to advance geopolitical interests? But either way you look at it, I think people are getting vaccinated and it's reducing community transmission, or it's a pathway towards economic recovery in Africa. So as the pandemic unfolds, I think we are going to see more bilateral, especially with holding of vaccine in the West. We're going to see more deal Nigeria, Morocco, making more deal with China and Russia. So when we talk about equity, what we're demanding right now, it's what I think fairness and transparency is very essential. Like South Africa paid almost more than double the price for AstraZeneca vaccine. And at the G7 event, I think last week or 2 weeks ago, France and UK, they talked about donating the excess dose vaccine. While it is understandable that rich countries protect their population, I think it is important for us to protect healthcare workers worldwide and the vulnerable amid the rise of several variants and increasing transmissibility. So it is important that we know that generosity is not solidarity. What we need at this point of the pandemic is fairness, equity, and transparency. So given the holding of vaccine in the West, right now, as we are demanding for a people's vaccine. And to do this, it will require Big Pharma temporarily suspending or waiving IP rights. But there are also challenges. One, we think that, oh, this is a pandemic, it should vary. But major opposition from the UK and the US, this was used during the HIV pandemic in early 2000, and we saw how the number of deaths went down vastly. So another way of achieving equity, talking about the CTAP, COVID-19 technology access tool launched in 2020 by the WHO, to share patent and trial data. But 9 months after, there are no significant contributions. However, we've seen AstraZeneca share data with Serum Institute, and we see what India is doing around neighboring countries, distributing vaccine doses, which should help to vaccinate their own vulnerable people. And we have also seen these in South Africa as well. So looking at the dynamics going forward, for us to achieve true equity in distribution, I think we have to address the inequalities that is reflected in the international economic order and the governance of many multilateral organizations and initiatives. Most of them which often reflect colonial patterns of extraction and exploitation. So in order to achieve true equity, we must address the undue influence of a small number of states. However, this process is very complex, but I think a first step, we must decolonize governments at the highest level, make it more democratic, more inclusive. While at the regional level, we must reimagine pandemic preparedness in Africa. This will entail building local manufacturing capacity in medicine and vaccine for African diseases and other pandemics. So the case to build a vaccine is more important right now. The COVID has made it very clear. And other reasons include a growing population, increasing coverage for immunization. But there are still challenges in terms of finance, but that is not just the reason. If Africans could get finance right now to produce vaccine on the way, they also need the markets. But most of these markets, like Switzerland, Geneva, where you have the major donors, like Nigeria, Congo, and Ethiopia, which have the biggest size of population, they are all gas dependent. So if Africa start manufacturing, the market is not even within Africa. So those are challenges, and a weak regulatory framework. But the good news is that there are opportunities right now in terms of finance. The World Bank and FSM Bank, they've, I think in total, as a country, could access up to like $4 billion in Africa. And the African continental free trade area provide an opportunity for economic of scale in terms of PP and other essentials. And we also look at the African Medicine Supply Platform and the African Medicine Agency, which is here to verify. these are opportunities that should be explored. In a reimagine global health security in Africa, we also want to see greater trade integration, because at the start of the pandemic, the scarcity of PPE and other essentials was placed a lot of countries in Africa in a disadvantaged position. And currently, a lot of countries in Africa, they are in recession, like for example, in my own country. So, and with falling prices of commodities like oil, I think there's greater need for economic integration in Africa to boost access to this service. Then finally, in a reimagine global health security in Africa, we cannot talk about it without highlighting the current effort of the African CDC right now. So investment in national and regional public health industry like African CDC, which have led the continental response, I think it is very vital. Like some of the successes include the creation of PAC, the Partnership to Accelerate Testing, which increased the country capacity from 3 to 43 within 3 months, and so many other initiatives. So this will entail commitment to the Abuja Declaration, which was made in 2001. But 21 years after, just 3 countries in Africa spend more than 50% of their GDP on health. And furthermore, we have to build public-private partnership in order to sustain most healthcare services. Like in Nigeria, we have what we call the CAR code, which is funded by the Dangote Foundation and other private organizations. And we also see what several some telecommunication companies are doing for African countries to access vaccine. Then lastly, alignment of donor priorities, national and continental agenda. I think this is very important moving forward. Like in the past, we've seen where countries sponsor just one disease program like AIDS, TB, malaria. Why these have made remarkable things, they are not well equipped to handle interconnected health challenges, just like COVID-19 pandemic. So it is vital that donors align their priorities with those of the country and the continent. So lastly, just to reiterate, I've spoken about Covax, spoken about CTAP and IP suspension. And in a pandemic like this, we have to remind ourselves that solidarity with the poor is no longer an act of charity or generosity. But I think it's the mechanism for protecting the welfare of all people worldwide. It is self-interest. So just like the mantra, none of us are safe until everyone is safe, especially with the emergence of several variants across the world. So thank you very much, and I look forward to taking questions, comments, and discussions.
Thank you so much. Irene Torres, take it away.
Thank you. Thank you all for joining us today. I'm very interested in learning more about volunteering for trials around the world, demanding greater solidarity. I've been closely following the COVID response in Latin America with a focus on Costa Rica, Ecuador, Brazil, Chile, and Argentina. And what we have seen, and this is an interesting lesson, is that the health responses to the pandemic itself were not as strong as organized as the primary health systems, which is what we originally had expected. And this probably was due to social unrest, economic stagnation, but also lack of transparency, lack of civil society participation in these countries. And I'm talking about Ecuador, Chile, Brazil, and Argentina, where also we had a massive migration from Venezuela, for example. We have a regional crisis, you can say. So the COVID vaccination has been a little bit different. Countries that were very greatly impacted, like Chile and Brazil, are doing much better with vaccination. Chile has vaccinated 1/4 of its population, and Brazil already has reached 6%, at least with 1 dose, and will produce its own vaccines very soon, hopefully by June 2021, this same year. The other countries, smaller countries like Costa Rica, which had a very good response to the pandemic, already has also vaccinated 5% of its population. And then we have Argentina and Ecuador had a very, very severe impact of COVID and also have vaccinated very, very, very few people. So how has this happened? Why is there no vaccine equity in some parts of the world, some parts of a specific region? How is it that vaccine is not reaching everybody the way it should be? Why is Chile doing so well and other neighboring countries are not? So massive immunization requires first anticipating, being able to negotiate, having the capacity, which Chile and Brazil have been able to do. But it's not only about obtaining the vials. We need means of storage. We need internal transportation. The Pfizer vaccine is expensive to store, expensive to transport. Not everybody has the equipment for this. And we even need efficient syringes. There has been talk about syringes that can prevent discarding residues and improve vaccine volume. And if you start adding up how many doses you lose per vial, it's actually pretty scary. So I'm not going to do the math now, but there's lots of talk about that. So what do we need to first discover the vaccine, manufacture, store it, transport it, and inoculate people? You know, even the syringe is an issue. We need alliances to develop capacities in low and middle income countries. No, so we need support from high income countries, and we also need support between countries. But what is really going on is that, as you know, high income countries are hoarding up to 5 times the vaccines they really need. Private companies in high income countries have received public funds to develop vaccines, but they benefit privately because they have to export all the supplies that low and middle income countries need for vaccination, which again does not include only the vials. It includes the transportation means, the storage means, again, the syringes. So what is the framework really globally, beginning with high income countries, is that they can get public funding for the research, for the science, but they need free enterprise in their own countries and internationally, because presumably this leads to better science. Restrictions in their framework limit the reach of science, the development of science. So they need the funding to develop the science, but the science cannot develop with other types of restrictions. And this is an important tenet of scientific enterprise, in which health theoretically is viewed and defended as a common good, but science is at the very limit between serving society and serving health and profiting, making money, and being a free enterprise. And this works both within high-income countries, but also across countries, between high-income and low-middle-income countries, and also across low and middle-income countries. And what is happening is, I like what Nelson said, that it's in our best interest, but I think that framework can confuse us, because we can not only do this because we want our own good by vaccinating others. We want a society in which some are not excluded. We want a planetary health that also avoids excluding some over others. And that's the problem with vaccine nationalism. And that is what brings us today here to discuss, in which vaccine nationalism is pretty much saying some population need to be protected before others or over others. So another issue that is linked to this is how the WHO recently established foundation as an independent grant-making entity is trying to engage with corporations, billionaires who may have funded these corporations or have their own corporations, that have leverage already over the Covax initiative, over the civil society engagement mechanism of Covax, to not have limits to their conflicts of interest. So basically what was already happening at WHO, in which WHO was requesting private funding to keep functioning, especially when the United States, for example, had blocked payments, is that now they will officially not have limits to any conflicts of interest. Now they don't even have to discuss them, disclose them. So apart from hoarding vaccines, high-income countries have impeded intellectual property waivers at the World Trade Organization recently, are thinking of enforcing a travel pass, but will also have a lot of leverage of the World Health Organization, which previously they had as country states, but now they will have as countries where these corporations function and are funding the WHO Foundation. So these are interesting dilemmas that keep arising because it's a very uncertain time, and things happen at a pace at which at some point we cannot even keep up. So we have been discussing this past year in Latin America is how do we strengthen WHO globally? Not only the regional offices, which is a whole other discussion, but how do we do it? And of course, the question always goes back to we need more funding. WHO needs more funding to have the capability to do this. But if we have no oversight of the funding mechanisms, much as the scientific industry works without much oversight, without much transparency, without much participation, they are all going to have finally influence over maybe the only mechanism we presently have globally to ensure inclusion of everybody, to find this vaccine equity, right? To achieve this vaccine equity. So this internationalism of the COVID-19 vaccine and future vaccines that we may need are closely linked to this clientelization of the population, in which citizens are patients, in which science provides equipment, devices, supplies, and in which our relations between countries are international. Vaccine industry relations are defined by science being at this limit between the common good of health and the private interest. And I think if we want to look into the future, we either want to revisit or redefine some of the elements of the role and position of science in society, or at least we need to make clear what conflicts of interest exist within the funding of the WHO, the funding of the scientific industry that's producing these vaccines, and to have greater oversight of these relations between organizations as well. I hope I did not talk too fast.
No, that was great. Thank you so much. And Dr. Hassoun, you are up last.
All right, thank you. And thanks so much for putting this amazing panel together. It's really great to connect with people on the other side of the planet who are, thinking about this stuff. So as other speakers have pointed out, the COVID-19 Global Access Facility, or Covax, is a collaboration that brings together governments, companies, international organizations, and others to try to increase the development and manufacture of COVID vaccines, as well as help distribute them around the world. So it's proposed giving countries vaccines in proportion to their population until each can vaccinate about 20% of its population, and it aims to distribute 2 billion doses through the end of this year. Covax is a really important proposal for combating the pandemics because, of course, pandemics don't respect borders. So until we're able to vaccinate the majority of the world's population, it will continue to circle the globe. There's a lot of vaccine hesitancy. So even in rich countries, we may have a hard time securing and maintaining herd immunity, even with highly effective vaccines. which is especially likely if people are going to require regular booster shots and we're getting this evolving virus, since the vaccines are difficult to store and transport. In our globalized world, our economic fortunes are also tightly intertwined. So some estimate that the COVID crisis is costing or will cost the world economy $9 trillion over the next 2 years, and it's currently costing about $375 billion monthly. Global partnership, I think, is the most viable strategy for overcoming the pandemic. But Covax isn't perfect. So poor countries will only get to vaccinate 3% of their populations initially. They've just started vaccinating people, and there's currently no plan in place to help them vaccinate more than 20% of the population. But rich countries will get to vaccinate up to 50% of their populations through Covax. Or perhaps because of the Covax proposal's limitations, there are competing proposals for ethical allocation of vaccine on the table, and I'm happy to talk about them in discussion. But I think most proposals like Covax fail to recognize the importance of having the largest possible health impact for people, irrespective of their country of origin or residence. So international distribution efforts often treat countries equally, partly because countries are voting members of international organizations. And similarly, Covax is working directly with countries. So proposals for international distribution, I think, should focus on individuals who suffer health problems rather than countries. Another point is that when wealthy countries prioritize their populations and are allowed to do that, through initiatives like Covax or other proposals for ethical allocation, I think we fail to treat people equally. And where poor nations lack resources or facilities that they need to vaccinate their populations, it's incumbent upon the international community to support their efforts. Fundamentally, I think we need to question the assumption that essential medicines and vaccines and other resources have to remain scarce. Because, of course, right now in the COVID pandemic, vaccines are scarce. The allocation proposals are assuming this kind of limited supply, which then means they're focusing on how do we allocate this limited supply to different places. And we have to choose who's going to get the first doses, even in countries. I think this shouldn't never have been the case. And the most important ethical questions have to do with figuring out not how to shift our resources around, but how we can address and prevent such tragedies in the future. Health frameworks should be repurposed and reimagined to improve manufacturing and distribution systems, increase access to trained healthcare workers and funding, and foster trust in the scientific community and community engagement. I think we should fundamentally rework the incentives for pharmaceutical research and development in order to overcome scarcity in the sector. So let me talk about each of those things. Although many rich countries will vaccinate their populations this year, poor countries may lack access to the vaccine for years, in part because there's limited global manufacturing capacity, or at least many people in those countries. And even if we can manufacture enough vaccines, many low-income countries lack sufficient cold chain infrastructure for distribution. Besides manufacturing and distribution, countries need more healthcare workers to address both the coronavirus pandemic and many other pressing health problems. And even where there's proper health infrastructure in place, we have to ensure broad vaccine uptake. So vaccine hesitancy is increasing, especially in populations with little direct exposure to how the virus affects patients. And vaccine hesitancy may delay herd immunity. So I think it's really important to partner with civil society organizations to reach people in remote communities and those with expertise in existing global vaccination efforts. Existing frameworks are being revamped to address the pandemic. For example, the Global Polio Eradication Initiative has provided expertise from their polio vaccination efforts to COVID prevention efforts in training COVID surveillance staff for detecting the virus through wastewater testing and distributing masks and hand sanitizer and doing contact tracing using tools derived from their polio programs. But we need to do a lot more. We should consider this as an opportunity to invest for the future. There will be other pandemics. There have always been other pandemics, And as climate change modifies habitats in a way that brings people into closer contact with different species, we only increase our risk of future outbreaks. In fact, we're not investing enough in fighting many other diseases besides COVID that already exist. Diseases like AIDS, tuberculosis, and malaria are ravaging the planet even as the coronavirus pandemic surges. Each of those diseases costs the world more than 160 million disability-adjusted life years in an average year in 2015, for instance. As policymakers are shifting resources to fight the COVID pandemic, it's interrupting service delivery and making other epidemics worse. The COVID pandemic is disrupting diagnosis, prevention, and treatment efforts around the world. So some estimate, for instance, that malaria mortality has increased twofold and that there'll be more than 40 million new malaria cases, and that there were more than 40 million new malaria cases last year. Building sustainable health infrastructure is arguably just as important as building roads, providing electricity and clean water. And the necessary investments will help enhance our efforts to provide these other things too. So we should be able to distribute essential medicines around the world to prevent and treat many devastating illnesses, not just those afflicted with COVID-19. And doing so will help us address not only the COVID pandemic, but prevent and address many other terrible tragedies. There should be vaccination systems in place so that every child can be vaccinated against a host of vaccine preventable illnesses. In the future, fair allocation proposals should also require countries to ensure open access to research and development data and resulting technologies. We need to reward pharmaceutical research and development, but we can do that with the kind of advanced market commitments that we've seen in Covax on the condition that they license those technologies for generic development and put them in the public domain so any company can provide the resulting technology at cost to the global poor. 80% of global manufacturing capacities is in generics, and there's absolutely no reason that Pfizer and Moderna need to charge something around $60 or $40 for a vaccine in a global pandemic. On the one promising proposal, I think, is to tie rewards for new innovations to their health impacts, which would delink companies' rewards for new innovations from sales volume. So currently, companies profit the most from treating but not curing chronic diseases of rich patients because they can continue to sell things like allergy medicines to people like me indefinitely, and that's very lucrative, right? So we have a great variety of allergy medicines and so forth, but companies lack the incentive to focus on many of the greatest global health problems, like malaria and tuberculosis, that primarily afflict poor patients. If we provide sufficient rewards for new innovations in proportion to their health consequences, we align incentives with that need, and we encourage companies to produce medicines that save the greatest number of lives and alleviate the most disability. Transparency about companies' research and development costs can help us ensure that rewards are sufficient and good measures of global health impact already exist. In short, equitable vaccine allocation requires many things. Sufficient funding, manufacturing supply, transportation and distribution networks, healthcare infrastructure, and workers are all necessary to administer the vaccine. Trust and transparency are also essential for vaccine distribution and uptake. But I think we should also fundamentally reconsider how we reward pharmaceutical companies for their efforts. Fair allocation should help individuals everywhere, and not just those of us who are fortunate enough to live in rich countries. We should institute basic health systems globally and support efforts to do research on, manufacture, distribute, and help everyone access vaccines and other essential medicines for COVID, but also for many other major global health problems. Anything less is inequitable.
Yeah, thank you so much to all you, our panelists. Indeed, it has been an interesting conversation going. And maybe at this point, just to to allow you each to ask questions to each other, if there are any, to the panelists.
I'm curious about the incentives that Nicole mentioned. How would that work? Because I have doubts about economic incentives trying to address an issue that's economic, if you will.
So can you say more about the concern? Because I don't quite understand. So yeah, maybe
Well, I didn't really understand what these economic incentives involve. How would that work?
Okay, yeah. So the thought was that right now, Covax, for instance, will have something called an advanced market commitment. So they say, if you develop a new vaccine that meets certain specifications, we will purchase some amount of it from you. And that gives companies a reason, right, to produce that vaccine. They're gonna make money, and it helps support that development process. Now, if all the countries collaborated and bought only through something like the Covax initiative, and could say to companies, yes, we'll buy enough vaccine to vaccinate the global population, but some portion, enough to make it lucrative for them. But we want you to make this vaccine then accessible for any company to produce, put it in the public sector. So they license it to any generic manufacturer that wants it. Then everybody's buying through the Covax initiative. I think we could get vaccines at a much more reasonable price. What we need to do is to align the incentives sufficiently so that we reward research and development, pay enough that the companies will do it, basically. And two, I think the reward should be in line with the health impact if we're going to look beyond just COVID and look at a variety of diseases. So if we're going to create a reward system for new innovations, we should pay more for those that address bigger problems and save more lives, basically. Does that make sense?
It does. I'm just not completely convinced. I have to think about that because, yeah.
I'll share a few little things on it, but also I talk a lot about it in my book. Or actually, the Health Impact Fund might be a good place to go. I'll pop some links in the discussion.
All right. Thank you so much. Any other questions around the panelists? Okay, so while we are thinking about that, so to our audience, if you have any questions, you can just raise your hand if you want to ask the question, and then you'll be unmuted. Or if you like, just type the question in the chat and we'll address it as we go by. So I'm going to take it, maybe let's begin from Nelson. I think your concept of vaccine nationalism is very interesting, and of course it's a concern for many people, especially people in low and medium income countries. But the conversation, or at least the question around vaccine nationalism, is how to balance the access to vaccines, especially between the country which is producing the vaccines and the poor countries that have no capacity and no spending power towards this vaccine. So how do you reason around that issue? I think you're muted, sorry.
Okay, can you hear me?
Yes, please.
Okay, yeah, thank you. That was a very great question. Well, I would say for countries that are not producing, like I think in Africa right now, at the moment, we just have several clinical trials ongoing, and in the West, vaccines have been produced. I think for us to get a balance, it's going to depend on who is, like how I say, it depends on who is affected.
I think you've accidentally muted yourself again, Nelson, sorry.
Can you hear me now?
Yes. Yeah.
Yeah. Okay. Like I was saying, to get a balance, like for COVID-19, how I say it depends on who is more like affected, who is impacted. Like in the case of the Ebola, when several countries were affected in Africa, we saw like this great response, trying to develop, make vaccines available to prevent the disease from spreading. This tropical colonial medicine from moving to the West. And for COVID-19, it was the opposite. We saw like most Western countries were more impacted, and in African countries, no or limited production. Talking about Covax, it's a very brilliant idea to bridge this gap between countries. But like I said, what countries say and do, what they say at the WHO executive board meeting at the UN, and what they actually do in reality is reflected in the inequalities in governance of these organizations. So what I think should be done, like I think decisions at this level should be more inclusive. Like if you look at the WTO right now, I think about 10 or more than half of the members, they want this waiver of IP. They want the suspension of IP. But if the US say, "Oh no, we don't want it," or UK or Big Pharma. So I think if we start making decisions more democratic, more inclusive, that way we will begin to arrive at true equity. So we must address those on undue influence. Like in the case of Covax right now, if 5 African nations say, "Oh, we want to waive," India and South Africa bring the proposal, and US state no. So true equity will demand in decision making that there should be true inclusion. It is understandable that each country would want to protect their own population, but there should be fairness, there should be transparency, at least in access to those. Like in Africa right now, like countries want, we say, okay, we have the money, we want to pay, like the African vaccine acquisition tax thing, we want to pay for these doses. Okay, give us access. But we are in a situation where most countries are made to compete with richer countries, even though they don't have the purchasing power. Like South Africa is paying twice the amount for AstraZeneca vaccines. So I think if there is fairness, if there is transparency, like we have in the African Medicine Supply Platform, it's a platform where all countries in Africa go and you make your order. We order, everybody makes their order. And at the end of the day, it is distributed. So if we have that kind of platform, that countries go, like they make a pre-order for vaccines and medical supplies, I think that will go like a long way to bridge the gap. And for those countries that are extremely poor, I think since we are in a pandemic right now, we have seen several variants of the virus emerge. So I think it is our best interest for a global solidarity. And like I also emphasize in my article and this talk, sustainability of this measure will depend on regional development. Because a case example is in India. India is producing vaccines today. A country like Sri Lanka and people around who could not afford it. Since technology was shared with the SII, the Serum Institute, so they are able to distribute vaccines to their neighbors. If that same capacity exists in South Africa right now and we could manufacture vaccines, I think that will go a long way, at least to protect most vulnerable people in Africa. Yeah, thank you.
Thank you so much for that response. So, from the Covax initiative point of view, I think it's right to say, I think from what even other speakers, panelists have mentioned, that there is need for oversight, there is need also for transparency. And who better to have this oversight than perhaps, I'm just shooting here, perhaps the WHO, which kind of leads me to something that Dr. Irene said about the role of WHO. Specifically, I'm interested in what do you imagine, Dr. Irene, what do you imagine should change in terms of oversight or regulation provision on the part of WHO towards Covax or towards the equal distribution or access of vaccines? Because I think it's fair to say that WHO is the mother of all health issues in the world. And frankly speaking, so far, it hasn't done much of a good job, because it seems that countries are still getting their way. Pharmaceutical companies are still getting their way. So what, if you had the ideal world, what would you imagine should be done?
Well, that's interesting. I think that one thing I would do if I had any power is learn more about Africa CDC, for example. I think they've done some amazing work at supporting and understanding locally how to respond to the COVID-19 pandemic. I think that was very powerful. And you see, Africa CDC does not work within the WHO framework. So I think that's one big step. Look there, how did it work? What did they do? What's going on there? Because we're trying to fix WHO within WHO and from the vision of the regional offices that grow from WHO and nurture WHO. It's in health, when there's an endemic issue, how do you snap out of it, right? So that would be one. The other is definitely, if countries are going to permit corporations to fund and get tax breaks, I don't know how it works internationally, but I guess big corporations get tax breaks by being solidarity with WHO. Well, those countries also need to create mechanisms to know where this money is going, just in the same way as if you're weaponizing a country with your private money. If that were the case, the countries would be worried about it, would be overseen where your money is going if you're buying arms or weapons for another country. So I mean, it's a radical comparison, but if you're weaponizing private mechanisms in WHO, which is an organization with a global interest, maybe countries want to have greater oversight. Where is that money coming from, and what is it being used for in WHO? Why not? And there you have countries that have huge civil society oversight, like in Scandinavian countries. So we also want to learn from them. How has it worked in those countries? Because if Sweden taught us something about making mistakes, is that they made their mistakes openly. And we could be very critical of how they responded to the pandemic, but we want to learn about how they manage. Of course, there's a culture in that country, but also they are willing to make sacrifices for that transparency, and they're willing to protect the consequences of that transparency. And I think that's also very interesting, because in Sweden, the mistakes that were being made transparently are not being punished. They're learning from them continuously. They keep on making some of the same mistakes, but they're learning from them and they're being transparent about it. And the oversight mechanisms are designed to learn from them. I think that those are some of the visions I have.
Thank you so much. That sounds interesting. Indeed, it seems that without transparency, an environment is created where there's lots of speculation, lots of unanswered questions that are going in and not coming out. And kind of, in a way, this leads me to Dr. Nicole. Something you mentioned. I'm more interested to hear about what do you imagine would be the best criteria for deciding who gets the vaccine first. Let's talk in the context of the Covax facility, because the Covax facility is at least supposed to be perceived as the fairest, initiative to get vaccines to everyone. So, but even within the Covax facility, I think there are still some things that need to be fixed. I'm trying to understand, for example, if I'm not mistaken, Ghana was among, if not the first country in Africa to get the Covax doses, right? But I also know that South Africa is one of the countries with the worst cases. So that begs questions. If South Africa, which has the worst cases, didn't get the vaccines first, and Ghana, which seems to be somewhat doing much better than South Africa, gets the first doses, what criteria is going there?
Yeah, I mean, I don't, I think you can find out about the Covax initiative and how countries have to kind of get approved to get the shipments. And so there's some kind of, readiness evaluation. And so that may play a role. Also, South Africa has, I guess, a more middle income country than some parts. So there's lots of things that could go into that kind of evaluation. But I think it's an open question, right? Like, how could you best combat the virus globally in a way that treats each individual equally and not prioritizing rich countries? So that's the first thing. Like, I think we kind of failed so far to do that, right? I mean, in the US, the vaccine's been here for months. We look forward to being vaccinated, pretty much everybody pretty soon, and yet many countries won't have received almost any vaccine. And so that's a major inequity. And I think we need to support efforts to, improve Covax, to fund it better and ensure that, they raise their bar a little bit in terms of trying to get the vaccine out there and trying to help. But also, there's the vaccine arm gets a lot of attention, but underfunding is not only a problem for that, it's also a huge problem for therapeutics and diagnostics and basic health system support. And I think we don't want to neglect that, because if as probably will be the case, not everyone's going to be vaccinated around the world, then therapeutics are really important too, and keeping people safe and so on. So yeah, I think it's important for Gavi to make sure that it's not captured by Big Pharma, basically. So there's a lot of, you read on their website, you have this International Manufacturing Association, like lobbying group for pharma, which is like, yeah, we just need to increase manufacturing like through traditional routes. And I think, no, you don't, right? No, I mean, there's parts of the world where they're clamoring for like the knowledge that would allow them to manufacture those vaccines. And absolutely, that knowledge and permission should be granted. I mean, they're not providing them. It's not like they're going to lose money in that process, at least anytime soon. I mean, they can still purchase them through Covax if they're competitive. And so I don't think Big Pharma needs to make the kind of money that it's going to make on the global pandemic. And I think we could speed things up a lot better if we had collaborated globally to purchase things through like monopsony power, right? Like through a global collective agreement. We're going to do this all, and we're going to supply the world equitably through this and get the vaccine to everybody. And the higher prices in which countries would then be supplementing lower prices, presumably, hopefully, in poorer countries, which, as you saw, is not happening necessarily. So, yeah.
All right. Thank you so much for that. And you've mentioned, or you've touched on something that I think all of you three have mentioned on the issue of funding. Now, obviously, this is a big issue, because on one hand, I think arguably the only way to increase manufacturing capacity globally is to perhaps increase funding. And maybe this would take the form of even setting up manufacturing facilities in countries that are not producing, as a way of building the output, right? But also, especially Nelson, you mentioned that there's need for the alignment of this donor fund with priorities, national as well as continental, with agendas rather. So it also again brings us somewhere close to what Dr. Nico and also Dr. Irene mentioned, that sometimes when people give so much funding, there's an inherent kind of I owe you that comes with such huge amounts of money. And I think somehow this contributes to these bilateral secret deals that are going on, where some countries are getting access to vaccines, even amidst some all this confusion around the access. So my question to all of you, perhaps to simplify it, to what extent is funding really a problem? Because I don't think funding alone would solve the current problems that we are having with access, especially equitable access.
Well, when you asked about Ghana, how did Ghana get vaccines before more severely hit countries such as South Africa? It was anticipation, the power of anticipating and requesting and negotiating the vaccines early on, definitely. Because the problem with the Covax initiative, as far as I know, is that if you were first in line, you would be prioritized. So there wasn't a theoretical prioritization. That is an issue. And if there were greater oversight, other decisions would have been made, definitely. And not only based on the capacity of countries giving input to the Covax initiative, but also on having the science to know this. I mean, for example, Ecuador and Peru have the 2 highest excess death rates in the world, not in the region, in the world. They should have been prioritized, absolutely. And again, it's not only about the vials. We need the storage, we need the means of transportation. I mean, I'm being repetitive, but again, we're focusing too much on the capacity to buy, to have the millions to buy the vials and pay, you know, a company to bring a plane with the vials inside, but it takes so much more. And thinking about the future, and that's why I like the question of Mabel posed for us to participate is, we are volunteers, but we want to volunteer if it's going to be fair. There's going to be equity. So equity cannot be based on a country's capacity to negotiate, to anticipate, to be first on the list, to have the means of immunizing everybody within a country as well. It's so complex.
Yeah, I mean, I agree. And I think also, you know, the funding piece is, you know, absolutely, you know, the money is where it's going, right? So it's not smart for developing countries to just try to outcompete each other. That's not helping. And I think the EU, for instance, is feeling that right now. Like they're very behind. They didn't succeed in that global competition. A few places like Israel did, but it's not how we should be doing it. And it's not necessarily going to benefit rich countries even to do it that way. So I think what we should do is we should, you know, require open access to data that can speed up the research and development of new vaccines when we get new variants. We should require companies to pool their technology and then sure, give them rewards that are sufficient to compensate for their research and development investments and additionally support new investments, however much you want. But then allow the generic production, allow any company to manufacture that and get it out there and ensure that we have equitable distribution of resulting products. And I think that requires global buying agreements. And then those companies, or those countries can subsidize, you know, the purchase of the vaccine for everyone. And I think, you know, it's a basic failure to respect human rights, what we're seeing.
Yeah, I'm just going to jump in quickly. I think that's very great question. I think with Covax, right, the issue, in as much as funding is a major challenge, but I think it's not the biggest. I think it's access to supply. You know, at the last G7 meeting, you know, we saw countries like the US committing more funding, like $2 billion, you know, to support Covax, and we saw the UK and other places. But without this money, where is Covax going to access the supply? Like before the pandemic, you know, global capacity to produce vaccine, I think at any point in time, they've never produced above, I think, 5 billion doses. And with COVID-19, we're thinking about 9.5 billion doses in a year. So even if we have all the funding, production is not scaled, you know, extra, just as we saw in the HIV pandemic. I think it's not going to go a long way. So to answer your question, yeah, I think funding is important, but I think access to supply, like in Africa right now, okay, we have a vaccine acquisition tax scheme, you know, and the World Bank and the African Import-Export Bank, they provided facilities like credit facilities for countries to prepare vaccine. And African CDC and the European Union, they've secured 670 million doses from AstraZeneca and Pfizer. But when this vaccine is going to be delivered, still unsure. So I think access to supply it's a major burden. That's why you see African countries right now looking at elsewhere from the West to China and to Russia. Yeah, thank you.
Thank you so much. Then just something outside the box, if I may put it that way. I think the focus mostly when we're talking about the vaccines and access is on American and European vaccines. But I think as Mebo did indicate in the intro for this event, is we have more than at least about 12 other vaccines that are either approved or in the line to be approved. So my question is, what role are these other vaccines supposed to play in terms of access as we are aiming for, equitable distribution and vaccine equity in general? Anyone can jump in on this one.
Well, that's an interesting question, but about the role, well, I think it's kind of obvious. The more vaccines available that have passed the clinical trials, the better, absolutely. But we have geopolitical issues that are difficult to understand from one country to the other. In the case of Ecuador, for example, we originally prioritized the European ones and the US vaccine for geopolitical reasons. And you can see that Chile, that is also part of why Chile has vaccinated so many people. They opened the doors and said, we want any vaccine. And they have the Sinovac vaccine, and they're doing really well. 25% of 1/4 of Chile has received its first dose. So the BRICS countries, right? The BRICS are showing there are other ways, definitely. And that's again the thing about learning, looking towards Africa CDC, looking towards Scandinavia in different ways, and now Russia, China, India. So Brazil is doing that. They've reached agreements. Well, they have the capability, the capacity also to manufacture. So they reached their own agreements, and they already importing the supplies, and they will start producing in June. So it's not only the role about exporting, but actually supporting, again, the manufacturing. And again, it's not only the vials. I'm sorry, I'm being repetitive, but definitely the more vaccines, the better in that sense. And I go back to the idea of what's the role and position of science in society and in these other countries' blocks. And science in that sense is the same everywhere. And it's for the health of everybody. Right? And if that is what these vaccines are achieving, well, I think we're all for it, right?
Yeah, I mean, I can add a little bit of sort of information if people are interested. So for Covax, right, you have to get WHO emergency use listing. And so they've only approved, I think, Oxford and Pfizer's vaccines so far. And that's the rigorous assessment of late stage clinical trial data, safety, efficacy, and risk. And it's some true in some cases in some countries that additional approval is also going to be required. So that stuff and be able to do it really quickly, I think, is a potential barrier to getting the vaccines out there quickly. But there's definitely those geopolitical issues, and China has been giving vaccines to people, but not everybody's going to be willing to use them, I guess.
Thank you so much.
Yeah, one more thought is, the AstraZeneca thing, right? Zeneca thing, where they've got, this worry about the vaccine in countries in Europe, and especially have been like, I'm not sure, let's wait and just be extra cautious. in the meantime, Canada has done the smart thing and been like, okay, give it to us, you know, so I think there's opportunities there too.
I have a quick question. This is particularly for Dr. Torres, though I think Dr. Evaborhene also speaks to this in some of his writing. So where does, and this is sort of bringing together some comments, where does the funding for the kind of stuff that's not the vaccines come from? And how do we, you know, because I think, you know, you're really drawing something out that like this panel was designed to sort of be about Covax and different approaches to procuring and distributing vaccines. But the other premise was that that's sort of not enough. There needs to be a bigger picture. So I'm curious if you can speak to that particular side of that health infrastructure side of the picture.
Well, interesting. Most regions of the world, there are gaps in immunization, but most regions of the world have the capacity. There are gaps in health workers and facilities. That is true. But immunizing is not rocket science. So I would think that if we want to, again, look into the future, strengthening primary health systems, there are some funding mechanisms in place that could help provide or strengthen primary health system. But that's an interesting point, because funding generally does not want to strengthen the systems as they think it's a responsibility of the state. In that sense, they are right, but they're funding lots of programs. Everybody's funding tuberculosis prevention and treatment. Why isn't that money just going directly into primary health systems? Well, we would prevent not only tuberculosis, but we would be in the case of COVID, we would have contact traced better. We would have the diagnostic capacity to identify and trace COVID better. And we would now have the capacity to immunize faster. So the question was, where is the funding for that? And that's a very important question, because we're only thinking again about the vials. So looking into the future, we definitely need to regain that discussion of health for all, which was one of the arguments in something that we wrote, monitoring the response in this part of the world. And the health for all agenda was pretty much displaced by quality, technology, efficiency, which are all good also for health systems. But we lost the health for all agenda, you know, the health as a common good, and how are we going to fund it and support it and scaffold it, and all these you know, key terms that people use when they write all these policy briefs and policy recommendations. But yeah, I think we also, and again, that goes back to the oversight and the transparency, because we also want governments that get money for this to be transparent about what they do with the money. And we also have that problem in this part of the world. There's so much corruption that what oversight will there be if there is money also for that? We're having corruption with vaccination. And I, in that sense, I mean, people are volunteering for a trial and then they bring the vaccines, and there's corruption in vaccination distribution within the country. So what are they going to do if they get funding for primary health systems that are in charge of the immunization programs? No, complicated.
Yeah, and Dr. Evaborhene, if you want to chime in too, because I know you wrote a little bit about the need for sort of economic integration across Africa, and obviously you're talking about donors needing to be in line with those receiving funds. So I thought you might have something to add as well.
Yes, thank you very much, Nilda. I think the funding for primary health care, resilient or pandemic, I said, first of all, like, we need the political will back in Africa. For us to do research and everything depends on the political will. The government that's ready to fund research. Even if we have donor contribution in the West, I think sustainability depends on the country itself. Yeah, talking about as trade integration, in Africa and epidemics arise. I think donor, like I discussed in my essay, like in 2019, the sum that was allocated for pandemic preparedness in lower and middle income countries of 41 billion is just 1%. So I think donor priorities should be aligned with national or continental. Like when the COVID-19 hit, you know, most health initiatives have been siloed. Like you have, like where I was working, you have the HIV program, tuberculosis, the malaria. You know, I think this issue has been a donor trying to get like tangible results, what they can measure. Like in HIV, you can measure like, oh, we reduce the number of deaths by this and TB by this. But if you put the money in the health system, general, it's going to take you a longer time for you to see, you know, those tangible results. So I think if we get to that point where we stop looking at the, you know, health system, like in terms of like immediate results that you could see, like when you invest this amount of money, you get this particular result. You know, we have to look at the broader picture, you know, strengthen our aspect of health system. You know, that's where I think we'll build something that's more resilient, that could withstand the future, you know, shocks.
Thank you so much, Evaborhene, and also thank you maybe for those questions. We are approaching our mark for time, so maybe the last portion I would like to get opinions from all of you is, I know this is something that has been quite aptly alluded to, the connection between the science and the health, because every country, everyone wants health, but for us to get the health, there's the science in terms of the research, in terms of the specific policies that guide, for example, manufacturing, that guide, you know, the entire process to get the actual vaccine. So to what extent is this policy portion or the science portion at play in terms of the unequal distribution that we are seeing? I'll put it blunt to say, could it be that maybe in the low, medium-income countries that have limited access, it's an issue of policy, whether from way back in terms of investment or other things, and maybe the improved access or prioritize access for the wealthy countries also rests on policy or the science of it, coming from way back, you know, adequate investment in R&D. I don't know what your thoughts are on that.
Can you just clarify the question a little bit? Are you saying that poor countries aren't getting it because they're not doing the research and development, or?
Well, that's actually that's actually part of the logic. I think it's fair to say in many countries, for example, this is something that Nelson mentioned, I think in one of his writings, many countries in Africa have not invested in research, and have not participated. I think he mentioned only South Africa, which was involved in some trials. So we see that there's a gap in terms of research, medical research or pharmaceutical research on the continent. To what extent does this play a part in the limited access?
I'm going to say very, very little. And the reason I'll say that is, you know, India has like 2%, you know, vaccines to cover 2% of its population, but it does do a lot of research and development. It has a large pharmaceutical manufacturing, you know, component. The Serum Institute is like the world's largest manufacturer. So I think that it's more, you know, who has the money, right? Like to buy the vaccines once they're produced. The companies don't care. I mean, there's also, you know, there's also the landscape of, you know, will they be allowed to export it? But the companies don't care where people are located. They just want to make as much money as possible. So I don't think the fact that they didn't do research and development is a consideration when they're thinking about who to sell their products to. Of course, if they had come up with something of their own, like China did, right, or Russia, then maybe that would be available. They'd also have to have all the manufacturing and distribution things in place and the resources to, you know, get them to people. So, yeah.
Just quickly, you mentioned policy within our country, but I'm thinking of the of the travel pass that is expected to be enforced worldwide. And that is huge international policy that's going to create additional problems. Not only we cannot get the vaccines, but then people cannot travel because they haven't gotten the vaccine. You know, it's a double impact of the lack of vaccines. And this international policy is based upon the premise that those who are worthwhile or prioritized or have the money, as Nicole is saying, will be able to travel and not the rest. And this has nothing to do with internal policy.
Yeah, I think in terms of access, I think it's all money and geopolitics. Like I give you an example, like in Africa, we talk about research component. South Africa is leading in terms of research and development. You know, they have the BioVac manufacturing facility, and then they have leading scientists in the world, like Dr. Shabi, who's led Oxford, Novavax, Johnson & Johnson. But if you look at vaccination, like Morocco, as of today, I think they have the highest vaccination rate in Africa, more than 2.5 million. So if you look at South Africa that is doing research and Morocco that is getting the vaccine, I think it's more geopolitical and who has the money, or so that is what I think. Though research, to play some role in terms of pricing, like we saw, in terms of South Africa paying double the price. It was said that it didn't contribute to the development as a kind of funding or but in terms of access, I think it's more of geopolitical and access to funding, basically.
All right, well, we're just about out of time. One thing that I will just mention is, we did an event about a month ago now that was on research and development in Africa, medical research in Africa, and sort of the directions it might take in the future. So that I think fits in pretty well with where we ended here, and on sort of optimism towards what that could look like and how that could improve responses to pandemics, and also, deal with a lot of these different issues in a lot of different ways. So if you go to our YouTube page, you'll see what that panel, and I'll just throw that in at the end here. So thank you all so much for joining us. After, in a few days, we'll circulate the link to the YouTube page, and anything else that's worth sharing. So thank you all so much again.